Welcome to this series of lectures on oral medicine. This one is entitled Bone Lesions. Basically, this lecture will cover some of the variety of bone diseases or disorders that are present, and we will begin with WHO classification of benign and malignant tumours of bone. And this slide indicates the classification of benign tumours with the designation, the number designation in red. It's an extensive list, but generally I think that you should just know one or two maybe of the benign lesions, especially perhaps a neuroblastoma and odontoma, both complex and compound type. With regard to malignant tumours of bone in the oral region, you've got the odontogenic carcinomas and a list of certain others again from the WHO classification. Apart from odontogenic tumours, then we also have cysts, odontogenic cysts. A cyst is a union or multilocular epithelial line cavity of various etiologies that contain liquid or gaseous material. So non-epithelial line cavities are classified as pseudocysts. So in clinical practice, both pseudocysts and cysts are generally referred to as cysts. Cysts may arise from alveolar bone or alveolar process or the soft tissues. Their growth is slow and expansive, and they may lead to swelling of the bone and soft tissues. Most jaw cysts develop from dental system tissues and are therefore referred to as odontogenic cysts. Odontogenic cysts are distinguished from non-odontogenic cysts, where odontogenic cysts can be further classified as developmental or inflammatory cysts. So cysts are classified according to location and histological structure of the cyst wall. And under this classification system for dental cysts, the origin of cyst epithelium and pathogenesis is taken into account. Cyst types classified based on origin of cyst epithelium are odontogenic cysts and non-odontogenic cysts, whereas cyst types classified based on pathogenesis is inflammatory cysts and developmental cysts. If we look at the WHO classification, odontogenic cysts, they may be developmental or inflammatory. So the developmental examples are follicular eruption cysts, gingival cysts of adult and child, lateral periodontal cysts, or glandular odontogenic cysts. Inflammatory cysts are radicular cysts, apical or lateral radicular cysts, or a residual cyst where a tooth has been extracted and the cyst has been left behind, or a periodontal cyst. Non-odontogenic cysts are cysts of the nasopalatine duct and nasolabial cysts. So this classification by the WHO is based on clinical, radiological and histopathological examination according to the organisation's 1992 by Kramer and Pinglewood. The new classification of the head and neck tumours published in WHO in July 2005, the presumably most revolutionary but also most irritating innovation of the new classification is the definition of odontogenic keratosis as benign tumours, meaning that they are now classified as keratocystic odontogenic tumours. So in summary, odontogenic keratocysts are now defined as benign tumours and classified as keratocystic odontogenic tumours. This change was based on the knowledge that odontogenic keratocysts closely correspond to neoplastic lesions because of their aggressive nature. Findings regarding genetic changes in Golden-Wolf syndrome, which involves nevoid basal cell carcinoma syndrome, have led to the reclassification of odontogenic keratosis. The It must be noted that the reclassification and new molecular genetic findings do not have any clinical implication in terms of treatment planning. So here's an example of a periodical radiograph showing part of a lesion adjacent to a crown of an impacted mandibular third molar. It's not really possible to view the entire lesion on a radiograph of this type. In fact, you need to take an OPG with a pantanogram to reveal that this radiolucency is a little bit more extensive and extending into the ramus, and this was a characteristic of oncogenic tumour. Assess the biological potential of the lesion. So does the lesion exhibit any radiographic evidence of limited growth? Therefore that indicates the benign neoplasm, or is it aggressive, indicative of malignant process. Because benign neoplasms of bone are usually encapsulated and slow expansile, they have a well circumscribed margin and with a corticated or sclerotic margin. They tend to grow around or displace, expand adjacent anatomic structures such as teeth. Malignant neoplasms, on the other hand, exhibit invasion, rapid growth, and they have poorly circumscribed margins, and they tend to destroy anatomic structures in their way. These are two examples of the top one being a benign process, the bottom one being malignant process. So bone lesions, assess the lesion on adjacent structures. Is the lesion expanding or eroding? Is the lesion invading the mandibular canal? Is the lesion invading the maxillary antrum? Is the lesion displacing teeth? Or is it actually eroding the roots of the teeth? If erosion is present, is that pattern irregular or regular? Because here are some spot diagnoses to have a go at just from the clinical radiographs. And the top one is a dental abscess. This one, multilocular radiolucency, is an arteriovenous malformation. This one, which shows radiopaque opacities around, generalized around, which is Paget's disease of bone. And here another radiolucency is an granuloma. So radiolucency is not associated with teeth. Common ones are residual cysts, where the teeth have been extracted, florid cementosseous dysplasia or ameloblastoma, keratinizing odontogenic tumour, KOT or OKC as it's mentioned here. Uncommon diseases are central giant cell granuloma, aneurysmal bone cyst, cemented ossifying fibroma, staph in the bone cavity, which involves the presence of salivary gland tissue and occurs below the inferior-dental nerve canal. Langerhans cell disease or central arteriovenous malformation. I have listed some general principles to deal with radiolucent lesions. It's not associated with teeth. So if we look at OKC or keratinizing odontogenic tumour, as it's now referred, they're usually well circumscribed. It could be uni or multilocular radiolucency. You could do an aspiration of the fluid, which will provide you with straw-coloured fluid, and if you analyse that, there will be a higher content of keratin. Microscopy, usually 6 to 8 cell layers of stratified squamous epithelium, hyperchromatic and palisaded or corrugated surface keratin layer. They behave more like a benign neoplasm. In fact, it is suggested to be a neoplasm. 30% occur after excision. Multiple KOTs are featured in basal cell Needler syndrome or Golden Bolt, where you have multiple basal cell carcinomas, epidermal cysts, bifid ribs, and it's suggested to be due to a mutation in the patch gene in chromosome 9. Treatment involves enucleation and curettage follow-up to monitor any occurrences. Chemical cauterization of the cavity with Carnot solution has also been carried out in the past. So here are some clinical photographs showing some of those presentations where you've got the plantar pits, basal cell carcinomas, and the calcification of forked cell line. We turn our attention now to fibroosseous lesions. These include fibrous dysplasia, cementosseous dysplasia, including focal cementosseous dysplasia, periapical cementosseous dysplasia, and florid cementosseous dysplasia, and then benign tumour of ossifying fibroma. This picture from Neville Van et al. Indicates swelling in the maxillary right region, which clinically shows expansion of the maxilla on that side, on the right side, and even on the radiograph you see increased radiopacity as well as increased width of the body and angle of the mandible, and also of the maxilla. So Jaffe-Lichtenstein syndrome involves polyostotic, which means many bones being involved, fibrous dysplasia with cafe au lait, coffee with milk type pigmentation. McCune-Albright syndrome also has polyostotic fibrous dysplasia, cafe au lait, and endocrinopathies such as pituitary adenoma, sexual precocity, and hyperthyroidism. This slide just indicates some of the genetic basis for these two syndromes. So if we again look at radiolucencies not associated with teeth, so basically focal cementosseous dysplasia, this appears like it might be associated with the teeth, but the teeth are vital. And again here, these lower anterior periopical radiolucencies. First thing to do would be to do tooth vitality, and then if you observe that over time you see that radiolucency becoming radiotape. Radiolucent lesions not associated with teeth, so the other one is florid cementosseous dysplasia, where multiple of these lesions occur along the mainly the mandible, often common in middle-aged African American females, and usually they're asymptomatic and may be some low-grade chronic discomfort. And the differential diagnosis may be residual system neuroblastoma or odontogenic keratosis. Radiolucent lesions not associated with teeth, an ossifying fibroma here shown in this radiograph associated with this expanded region, and you can see that it is a well circumscribed radiolucency initially, which probably would become more radiopaque with time. So if we go back to odontogenic tumours, ameloblastoma and anormatoid odontogenic tumour, odontogenic fibroma, myxoma, there's a whole list of conditions that come under this title, but probably if you just focus mainly on ameloblastoma, which was a term first suggested by Ivy and Churchill in 1930, incidence rate is 11 to 13.5%, according to Regeziel et al. And Bailey et al. Most common in Black Americans in the 30 to 40 year age group. Rare in children. 81% occur in the mandible, especially in the retromolar area. Maxillary, 50% anterior and 43% posterior, according to Waldron. Unisex cystic occurs more in a younger age group, in that teenage to early young adult. Mainly contains a tooth, or may appear like a dentary cyst, and more occurs more in males. Clinically, it's a slow-growing tumour, asymptomatic. Swelling may occur, but you get eggshell crackling on palpation. Root absorption and paresthesia also may occur. Radiographically, they're well-defined round multilocular cyst-like radiolucency, typically scalloped. May appear like a kerocystic odontogenic tumour, other jaw tumours, or hyperparathyroidism. Microscopically, you may have a variety of patterns: follicular, plexiform, or plexiform unicystic, and others. Again, a quick spot diagnosis on these 4 radiographs on the slide. One's a multilocular ameloblastoma at the top here, multilocular dentagerous cyst, which radiolucency enveloping the crown of an unerupted tooth. Again, this one is a unilocular ameloblastoma, and this one is a kerocystic odontogenic tumour. Behaviour and management. It's a benign, slow-growing, infiltrative lesion. Recurrence varies between the types. Wide excision margin of 1.5 centimetres of normal bone is what's universal. Unicystic have a lower recurrence rate, according to Robinson et al. Maxillary ameloblastomas can be potentially lethal because of expansion into vital structures. Other variants: primary extraosseous or peripheral, which is very rare, but that does occur in the soft tissues. Malignant ameloblastoma, where pulmonary and nodal metastasis occur, that's again very rare. Ameloblastic carcinoma, this is an ameloblastoma that shows cytological features of malignancy. Later stage appears like a squamous cell carcinoma, and it does cause pain, and there's more rapid growth than other ameloblastomas. Radiographically more ill-defined radiolucency. Other variants: primary intraosseous carcinoma, which is a squamous cell carcinoma, and that's excluding mucoepidermoid, 3 types, reasonably good prognosis with radical excision. And they could be carcinoma originating in an odontogenic cyst, it could be a malignant change in ameloblastoma, or an ameloblastic carcinoma arising de novo, or from an ex-ameloblastoma or ex-odontogenic cyst. Or then you can also get keratinizing or non-keratinizing intraosseous carcinoma arising de novo. So differential diagnosis: beware of keratinizing odontogenic tumour with hydrophic degeneration. They may appear like stellate reticulum. Intraosseous salivary gland tumours, especially adenoid cystic carcinomas, may look similar, but that's rare. Odontoameloblastomas also give rise to both ameloblastoma and a composite odontome. Mainly in the younger age group, may look like an ameloblastic fibrodontome. So sometimes you can get extraoral tumours that resemble ameloblastomas, such as a craniopharyngioma and adamantinoma of the long bones. So here on the top left we've got a histopathology of the plexiform pattern and a follicular pattern just beneath that, and on the other side you've got craniopharyngioma and a craniopharyngioma which looks like a calcifying odontogenic cyst. Here the radiographs show multilocular ameloblastoma, unilocular ameloblastoma, another unilocular ameloblastoma, and a calcifying odontogenic cyst. Periodontal radiolucencies. You can have the endoperio lesions, which you'll learn about in endodontics or periodontics, or you can get Langerhans cell disease as well. Leukemia also affecting bone can cause bone resorption and radiolucency associated with periodontal margins. Then the teeth may appear to be floating. Scleroderma, here you get thickening of the bone around the teeth, widening of the periodontal membrane space, as well as condyle and coronal places may undergo resorption. Osteogenic sarcoma, the radiograph is not that clear, but it's a malignant neoplasm of osteoblast, and early lesions will show irregular widening of periodontal membrane space, and it's more common in the posterior mandible. Unilocular radiolucency associated with the crown of an unobstructed tooth. In this case, it's an adult. There's cortical expansion present. So your differential diagnosis has to include dentadura cyst, odontogenic keracyst or keracystic odontogenic tumour, ameloblastoma, ameloblastic fibroma, pneumatoid odontogenic tumour, or COC, calcifying odontogenic cyst. This one turned out to be a calcifying odontogenic cyst or pinball tumour, and surgical resection follow-up has to occur because you can get multiple recurrences. Initially it's radiolucent, but it will eventually develop calcification. That's why it's called calcifying epithelial, producing a mixed radio vision radio clearance. Thank you very much.